Good morning, everyone. So, welcome to my presentation on Connecticut infant mortality and delivering culturally sensitive care. This whole presentation is based in anti-racist practice. I'm sure most of you are aware the basics of that. This is a little bit more in depth in some areas, and then also just a review. Okay, the objectives of this presentation are understanding current infant mortality trends in Connecticut, identify racial and ethnic disparities in outcomes, examine contributing factors, including structural inequities, define culturally sensitive care and practice, and apply strategies to improve patient-provider interactions. So, defining infant mortality is death before age 1, and when this occurs, the rates or just the general occurrence is a key indicator of the population health, and these reflect maternal health, quality of healthcare systems, and social and economic conditions. Racial disparities in Connecticut and key contributing factors. So, Black identifying infants are 2 to 3 more times likely to die than white infants. There's persistent disparity over time. Although there have been state improvements, Connecticut did declare racism a public health crisis. These disparities reflect systemic inequities, not biological differences. This is kind of new. We're still moving away from biological differences as being a key factor. And then contributing factors may be the following, such as limited access to high-quality prenatal care, especially in those, healthcare desert areas, chronic stress and weathering, structural racism, socioeconomic inequalities such as housing instability or food insecurity, which we know is big in Bridgeport right now, and differences in healthcare experience. Okay, so what does infant mortality look like in Connecticut? So the Connecticut infant mortality rate is 4.4 to 4.5 deaths per 1,000 live births, which is lower than the U.S. average of 5.4 deaths per 1,000 live births. The U.S. still has the highest infant mortality rate among other high-earning countries. Connecticut is ranked among better performing states for infant mortality. There are significant disparities that persist across racial and ethnic groups within the U.S. The white infant mortality rate was 2.4 deaths per 1,000 live births. The Black infant mortality rate was 9.6 deaths per 1,000 live births. And the Hispanic infant mortality rate was 5.5 deaths per 1,000 live births. 12.6% of Black identifying babies are born with a low birth weight, which puts them at a higher risk of developing serious health outcomes or having other developmental consequences. Okay, reviewing birth outcome disparity. So Black identifying infants are more likely to be born low birth weight or preterm, and the low birth weight risk for Black identifying infants is 2 times higher when compared to white infants. All these factors strongly predict infant mortality, and we know as said in the beginning of the presentation, that infant mortality indicates population health. So when we have high factors for infant mortality and high infant mortality, we can then infer that there are serious inequities in the population health alone. So the role of structural racism and implicit bias in healthcare. Structural racism in healthcare systems impacts the access to care, quality of care, and patient trust. And income is not the defining factor for healthcare outcomes, and additionally, lifelong exposure to discrimination affects maternal health. And then unconscious attitudes influence clinical decision-making, pain assessment, and communication style, which then can result in delayed diagnoses and misconcerns. These both have a direct impact on maternal and infant outcomes. So what is culturally sensitive care, and why does it matter for infant outcomes? Culturally sensitive care is care that respects cultural beliefs and values, addresses language needs, and recognizes social context. It goes beyond awareness and requires action. And culturally sensitive care has a strong focus on patient-centered care. With this in mind, though, learning culturally sensitive care and addressing bias takes time. So starting with just awareness is a good step at first, and then just knowing that action is required to be able to provide that quality kind of care for these marginalized groups. And then also mothers receive culturally sensitive care when it leads to better outcomes for both mom and the infant. This care improves patient trust, engagement in care, and communication accuracy. And then that care leads to better prenatal care adherence, earlier interventions, and improved maternal health. So, workforce diversity and evidence supporting culturally sensitive care. Studies have shown that culturally sensitive care can bring big improvements, such as improved satisfaction and outcomes and reduced disparities. And strong provider patient communication has been linked to better adherence and reduced complications. But keeping in mind that these can only occur when culturally sensitive care is being employed. And then increased diversity in healthcare workforce also brings major improvements, such as improved patient-provider communication and enhanced trust. And evidence has also shown that diversified workforce can reduce Black infant mortality, as patients often feel more understood and supported when they are being cared for by a provider who has a similar background, and that allows them to engage with the provider more and really feel comfortable asking those important questions. Moving on to effective communication strategies that support culturally sensitive care. This looks like using open-ended questions, such as questions starting with how, why, or what. Also practice active listening, so eye contact, nodding, paraphrasing what the patient has communicated, and reflecting whatever feelings the patient is sharing with you. Avoiding assumptions, validate patient concerns, and using the teach back method. So when the patient has been explained something, you have them explain it back about what they need to know or do in their own words, which can ensure that they understand what they need to do rather than just memorizing what they've been told. And then, when applicable, ensure that there's good language access, so bringing in an interpreter. And then how to address implicit bias. This is really hard. A lot of us have biases that we don't even know about, or maybe we know a little bit about, and we don't realize the kind of work that needs to happen to address these. So this is engaging in self-reflection and self-assessment, and acknowledge and accept implicit bias and its impact. Also ensure that cultural and linguistic competence is well incorporated into the clinic. That's going to take work. That's not going to happen immediately. Participate in bias training. Hopefully that can be put on by the agency. And then also, this is really important, combat hardwiring. So neuroscience can help combat the hardwiring and address the conscious biases that we learned from environments when we were young. And so you might be able to do this by engaging in consistent periodic self-assessments that can help the brain correct self-biases for future interactives. And then on a quarterly basis, collect 10 to 15 cases, review, and determine if the treatment received was adequate or disparate. And so doing this really allows us to reflect and think about our own work, which can be really uncomfortable when we realize that maybe we haven't done something right. But taking the time and moment to think about that and decide how we can move on is the best step, rather than just ignoring what happened or shaming ourselves. And then how to build trust with patients. So introduce yourself clearly and avoid robotic going through the motions interactions. As healthcare providers, it's super high risk because, there are certain processes that have to happen. Take the time to just introduce yourself, let a little bit of your personality shine through. Ensure that procedures and decisions are explained and not just, told to the patient and they feel like they don't have any other option. Encourage your patient to ask questions and acknowledge their concerns, and then provide continuity of care when possible. It's also important that we're speaking at a 6th grade comprehension level, because that is the literacy that most of the U.S. has. Using complicated clinical jargon is confusing and often alienates patients when they don't understand, and it makes it hard for them to engage in their patient-provider relationship. And then incorporating cultural context and community approaches. So when working with a patient, asks about beliefs around pregnancy and birth and family involvement. Respect cultural practices when safe, and try to be open to exploring those cultural practices. Healthcare providers have gone through all this training in school. It can be easy to feel like you know what's best. But coming in hard like that can just make the patient feel less understood and not really want to engage. You might have to collaborate with doulas or community healthcare workers. And just remember, you don't have to be the only expert. And then also ask yourself how care can be expanded. So, are more community health programs needed, or can there be collaboration? And can there also be collaboration with home visiting services? Ensure that culturally aligned care models are being supported. So, if there are old models being used, which is common, how can you bring in a new model that has more of a cultural focus? Ensure that you're partnering with local organizations, and get out and engage with the community if you can, so you're not just someone who's sitting in an office. And then also, some system level changes certainly need to happen. It doesn't just happen at the individual level. So, ensuring that improved access to natal care can happen, encouraging investment in maternal health programs, increased workforce diversity, addressing social determinants of health, support implicit bias training. And it's important to know that many or most of these changes are not directly on you, but your advocacy and participation when these happen make these opportunities possible and allow them for them to potentially be consistent. And then just some key takeaways. So Connecticut has low infant mortality overall, but disparities are still widely evident. And we can infer that that's mainly due to the population health. The Black identifying infants face significantly higher risk, and then Hispanic identifying individuals face the most risk next. The causes of infant mortality are rooted in systemic inequalities, but providing culturally sensitive care improves outcomes greatly. Healthcare providers play a critical role in delivering that care and can influence population health. Negative culturally sensitive care can alienate patients, but positive culturally sensitive care encourages patients to engage. And then also acknowledging that everyone has biases, but thinking about what those are and how to address those is the first step before taking action to actively correct those and other biases is great.